thank you for joining us, and welcome to MLI's Community Collective, Harnessing the Power of the Community to Battle Obesity, an activity supported by an educational grant from Lilly. Now, this is the second of a three-part series, Practical Applications of New and Emerging Data. MLI is honored to bring this to you in partnership with the Colorado Obesity Society. If you missed part one, just use the same link that you used to join us tonight, and you'll be able to watch the recording for part one from that screen. Now, next week, we're going to meet all together for a live in-person event at the Welton Room in Denver on Tuesday, November 12th from 6:30 to 8:30 p.m. Our hope is that after listening to both of these presentations, you'll come for a very informal event, no slides, where you can ask your questions and talk about your challenging cases. This exclusive event is just for you to network with your colleagues so that you feel comfortable making a difference in the lives of your patients who may face the challenges and comorbidities that come with an overweight or obesity diagnosis. And don't worry, if your colleagues weren't able to join you tonight, this information will be available to them at their convenience, and we'll put that link in the chat for you so they can view it prior to our get-together next week. So tell your friends and let's make it a date. Now, before we start, please join me in warming up with a few pre-test questions. Please answer on the pop-up on your screen.
Just trying to be aggressive towards you and not
Shh.
just let me know.
I'm on.
Okay, thank you. What is your specialty? Again, just answer on the pop-up. Thank you. Now, pretest question number one. Mr. J is a 50-year-old Caucasian patient with a body mass index of 34, which is categorized as class 1 obesity. If his waist circumference is 122 centimeters or 48 inches, what is his disease risk relative to normal weight and waist circumference? Right. Pretest question number two. To facilitate shared decision-making, what counseling and education points would you provide a patient regarding a second-generation AOM to allow them to make an informed decision about their therapy? Thank you for answering. And the last pretest question. A second-generation AOM was initiated in your patient 2 weeks ago. They report that they've been experiencing some GI issues. Which of the following is the best way to manage these common side effects? Okay, thank you for answering. So we will be monitoring the chat. Feel free to put your questions in there and we'll ask them in the end. And thank you for all of those who have joined us on YouTube. Now, with all that said, it is my great pleasure to introduce one of the leading experts in the field of obesity medicine, Dr. Abby Blindstein. Dr. Abby Blindstein is the founder and medical director of multidisciplinary obesity medicine practice called Healthful Life MD, where she currently practices in Golden, Colorado. The multidisciplinary approach includes a certified nutritionist, a registered dietitian, a certified trainer, specialists in health psychology, sleep disorders, trauma and eating disorders, and a chef specializing in culinary nutrition. She also provides coverage for the medical teams treating inpatient and residential patients at the Eating Recovery Center in Denver, Colorado. And she cares for pediatric patients with obesity in the primary care setting in Thornton, Colorado. She is board certified in internal medicine and pediatrics and is a diplomat of the American Board of Obesity Medicine. She is the current Colorado State Advocacy Representative for the Obesity Care Continuum for the Obesity Medicine Association, and she is part of the working group developing the Colorado Obesity Society. In 2016, Dr. Blindstein was recognized by the Obesity Medicine Association as Candidate of the Year. She has served on the Pediatric Committee, the Advocacy Committee, and as a member of the Speakers Bureau of the Obesity Medicine Association. Dr. Blindstein, I really appreciate you being here with us tonight, and I'd like to turn it over to you. Thank you.
Thank you so much. That's great. And thank you everyone for joining us on this kind of cold, snowy day here in Colorado. So I wanted to get started talking a little bit about what I consider the tenets of obesity care in my practice. And the first one really is that obesity is a chronic disease, but it is treatable. And when we think about obesity as a disease, a lot of different things really impact a patient's weight. That includes age, race, gender. And I realized let me make this more viewable for you all. There we go. It can be impacted by trauma history. A patient's medical history can influence their weight. Medications that they're currently on, medications that they've been on in the past, a lot of different things, genetics, epigenetics, all of those things can influence a patient's weight. And it's really important that we consider those things because, treating the individual patient and really identifying the causes of the patient's obesity will improve outcomes for these patients. And my second tenet is that patients deserve optimal treatment for any disease, and obesity is really no different. But the reality is only about 2% of patients that have an on-label diagnosis for anti-obesity medications receive those medications. And some of that has to do with weight bias. Weight bias is really common among physicians. I have a patient who came to me and she described, she said, every year I go for my annual exam with my primary care physician. And she said, I really like this doc and I've been with her for many, many years. But the first thing she says to me is, oh, I see you're still obese, and she said, it just makes her shut down. She doesn't really hear anything else that happens for the rest of the visit. And interestingly, this patient, she trusts this doctor. She's seen her for years. She continues to see her despite, her saying that, but it really impacts her ability to get help from this doc, to talk to her about it. And she feels a lot of shame in that visit. And so I would really encourage us to, not be that doctor, right? But the other thing that's limiting is a lot of times, doctors have misconceptions about anti-obesity medications. So we might think, that anti-obesity medications really are no better than, intensive lifestyle and behavioral treatment. Maybe we don't think they're really for long-term use. Some docs may feel that there are safety issues around these medications, and it really limits their prescribing of the medication. So hopefully we can learn some different today. Medication. Oh, and I'm trying to move my slide and it's not moving. Oh, sorry. Medications are an important adjunct to obesity treatment. Most patients that come to see me for treatment of their obesity have tried a number of different things on their own before they see me, and they've been variously successful. They've lost weight and probably lost weight a number of times only to regain it. And so to postpone medication when a patient comes to me really doesn't make any sense. And so really to, offer medications to patients is helpful. And we know that patients are 2 to 3 times more likely to lose, meaningful weight, which is about 5% or more weight loss when they have an anti-obesity medication versus when they don't. And the other thing is medications are really important when we think about sustainability and maintenance of that weight loss. So we want to think about it for both things. And finally, I always think patients should be healthier after treatment for obesity than before, and the changes should be sustainable. So we really have to pay attention to how we're helping our patients to make sure that they really are staying healthy as they're losing weight. One of the things that we can think about when we treat patients, if we're thinking about individualized patient care, is, could you actually phenotype obesity to help guide treatment? And Andres Acosta did a really interesting experiment a few years back. He's out of Mayo, but he was looking at that very question. And so he actually did testing for patients to divide them amongst different categories. And so he said some patients he thought sort of had hungry brain, what he called hungry brain, which is decreased satiation. And when we think about, decreased satiation, is that not recognizing fullness. So what he did is he took patients, he had them do kind of an ad lib buffet and eat as much as they wanted. And the patients that had the highest 25% of calories that they ate in that setting, he called hungry brain patients. He looked also at decreased satiety. And so those are patients that really feel hungry between meals or get hungry sooner after a satisfying meal than you might expect. And he called those patients hungry gut. And he tested those patients by doing gastric emptying study on them. And those that had the most rapid gastric emptying, he called hungry gut patients. He also looked at emotional eating or emotional hunger, or what we call hedonic eating. And he actually did an emotional eating screen on all patients. And those patients that scored highest on that, he called those patients, emotional eaters. And then he also looked at metabolic rate. And so he tested resting energy expenditure on patients, and those that had the lowest resting energy expenditure or decreased energy expenditure, he called those slow burn. And then he treated those patients specifically. So the hungry brain patients, he ended up putting on phentermine topiramate. Hungry gut, he put on a GLP-1 receptor agonist. At the time, it was liraglutide. Emotional hunger, he put on bupropion, naltrexone. And then for the slow burn patients, he put them on phentermine. And then he compared them to a group. He actually just randomized the controls to medication. So every patient in this study was actually put on medication. And what he found is that that patients actually lost twice as much weight. Those patients who were phenotyped and put on specific medication for their obesity. And so, I love this study for a couple of reasons. And one is that I really think it helps patients to recognize, when I talk about it with them, that there's something physiologic that's going on and that it can be treated, because so many patients feel shame and feel judgment and internalized bias towards themselves, around these issues. And I think it really helps to clarify that. I think it also helps to clarify that, bias among physicians, to see that there is something physiologic, that obesity is treatable. And if we're thoughtful about how we treat patients and we think of obesity as a disease, we actually will have much better outcomes and much better success for our patients. When we think about hunger, patients don't eat for hunger alone. There's a lot of different reasons why patients eat. So, there's social, emotional, and behavioral reasons. We can think about kind of environmental reasons. There are food deserts where patients don't have good access to healthy food. It could be as simple as there's food in the lounge, right? You think about holidays and there's cookies and candy and stuff as we're entering the holiday season, all over. And so that exposure is, there's sort of triggers to eat that way. We can also think about things like hedonic eating, and so emotional eating. And lots of patients struggle with emotional eating. They can struggle with stress eating, but we also think about binge eating disorder and actually eating disorders, night eating syndrome, those kinds of things. I have a lot of patients who come to me, and I wonder how many people have heard this, but they say, I eat when I'm bored. And when I actually tease into that a little bit more in detail, it looks like it's actually isolation. So loneliness can be a trigger for eating for people. There's habitual eating. People have kind of family culture things around their eating. They might think about clean plate club. I have to finish everything that I have on my plate. Going to the movies, eating popcorn, sort of habitual eating. A lot of people eat when they're fatigued or eat to take a break, right? We have a lot of patients who are working all day from home and they don't give themselves permission to take a break, but we all have to eat, right? And so they take that, so they end up eating more because it gives them an opportunity to take a break break during the workday. And then, of course, there's all the physiologic reasons that we think about for eating. And so the central hypothalamic issues in the eating and the hunger satiety circuit in the brain. There's endocrine and gastrointestinal hormones that impact things. So we think leptin and adiponectin. We can also think about all those gastrointestinal things like the GLP-1, the CCK and some of those things as well. And then genetics also influences feeding behavior in patients. So when we think about anti-obesity medications, this is a very busy slide, so I don't want you to feel overwhelmed with it. But what I'd like to really point out is that we know a lot about where these anti-obesity medications work and how they may benefit patients who are struggling, with obesity. And so if we look, we have kind of the hungry brain section here where it has the POMC and CART neurons, which actually will decrease when they're stimulated food intake. We have the NPY and agouti-related peptide part of the brain, which will increase food intake, when it's stimulated. And then we have this hedonic eating center of the brain. And so, there's dopaminergic neurons and that sort of reward center around eating as well. And you can see we kind of know where a lot of these medications have their action in this circuit. Naltrexone over here in the anorexigenic section, and bupropion also has impact over there. The GLP-1 you can see has impact here, but it also actually impacts dopamine and reward centers, which is really interesting. So it's affecting a couple of different places in that hunger satiety circuit in the brain. We see phentermine here. And so there's a lot of different areas, and we're aware of where the medications can be helpful. If we think about gut hormones as well, we go to the hungry gut section, right? And GLP-1 and impacts, those sections as well. And so we have those hormones. So, when I think about talking to patients about this, I would tell you, I am not doing gastric emptying, studies on all of my patients, right? But I can ask questions to kind of get to what really might be impacting a patient most. And so I ask patient things like, well, what have you tried in the past to lose weight? What worked? What didn't work? What's made that weight loss difficult in the past? I talk to patients about satiation. Do you recognize fullness? Do you feel like you eat until you're over full sometimes? And I ask them about an ad-lib buffet. If you were at a buffet, you could eat whatever you wanted. Do you feel like you might eat more than other people? I talk to patients about satiety. Do you feel hungry pretty soon after a meal? And obviously what a patient eats impacts that, but you can still get an idea about what's happening with patients if they're not staying full between meals and really feeling snacky between meals. I can ask patients, and this one's a little trickier, but that slow burn question, do you feel you can't eat as much as other people without weight gain? Do you feel that you are gaining weight despite exercising? And, a lot of patients will describe, when I was doing, several different sports and up through college and stuff, I didn't gain weight. But once I stopped that, it was really hard for me to maintain. And then I always ask patients about emotional eating, cravings, compulsions, food triggers. And I actually do an eating disorder screen on all of my patients. And as it turns out, about 30% of patients who seek care for weight loss with physicians have binge eating disorder. So if 30% of the people coming to see me have binge eating disorder, I better be screening or I'm going to miss it. So let's talk a little bit about patient care and how I approach a patient. This is Donna, and she's 26 years old, and she actually came to me because she wanted to lose weight prior to pregnancy. She had a history of PCOS, and she actually had prediabetes. Her hemoglobin A1C was 5.7. Her BMI was 33. She actually was exercising regularly, 60 minutes, 3 days a week. She struggled with emotional eating, and she says she just feels hungry all the time. And, she was on metformin in the past for her PCOS, but really didn't tolerate doses that were higher than 500 milligrams. And so, I started thinking about, how can I best support this patient? And if you looked at this patient and you said to her, you need to eat less and exercise more, you can see how it's not going to be helpful for her, right? You tell her to eat less and she's hungry all the time. And it's really difficult to do that. If she's exercising 60 minutes, 3 days weekly, she could do more, but that's clearly not what's going on with this patient. So I really felt like she was a slow burn kind of picture. And I put her on phentermine, which is also obviously going to address that kind of hungry all the time feeling that she's having. It's going to give her a little bit of stimulation around it. Actually increases the resting energy expenditure in patients, as well as decreasing, hunger and appetite, and that hunger satiety circuit. And what's interesting is it also can be helpful for meal choice, for food choice. So I thought it would be a good choice for her for those reasons. Put her on a partial meal replacement plan. She was doing 2 shakes a day and then a whole food meal, and then monitored exercise program. And she was followed by a dietitian as well. So here, I kind of mentioned this, but we know that phentermine works in these dopaminergic neurons. It does seem to have some impact as well on, on this setting here, and decreasing in PY and some other things, probably through the norepinephrine pathway. And then it does, it triggers some increased resting energy expenditure. And she did great with this medication. So she actually lost 30 pounds, which is 16% of her body weight over 5 months. Within a couple months, she was actually off the meal replacement. She was doing, mostly whole food, but had a shake for breakfast usually. And she lost 6 inches at her waist, which we know, and we'll talk about a little bit later, is beneficial for her metabolic health. And then 3 inches at her hips. Her A1C dropped from that 5.7 to 5.1, which is really great for risk, and also will help her in terms of her pregnancy. And she's strength training with high intensity interval training 3 to 4 days weekly, with, under supervision with the trainer, which really helped her establish that habit of exercise, or, reinforced what she was doing already. So she did really well with this medication. When we think about phentermine, we do want to remember, right, this patient wanted to get pregnant. We don't want to be pregnant on phentermine. So I want to make sure that she's on some other kind of birth control when she's taking this medication. And the side effects that I talk to people about, oftentimes they'll get dry mouth, they can get headaches from it, constipation. Those are the most common things that I see, but sometimes it can cause maybe palpitations. There's very little increase, as it turns out, in heart rate and blood pressure in studies, so it can be very safe that way. And the other thing is, when phentermine was approved, it was approved for short-term use. And so, it's 12 weeks is what you're supposed to be using it for. But the reality is, we know that really doesn't make sense when we're trying to treat this chronic medical condition. And there have been safety and efficacy studies on phentermine for long-term use. And so what this diagram shows is patients who used it for less than 3 months, this short-term, use of it, and then went off. You can see that they did lose some weight, but they actually had regain over time. The patients actually lose weight over the first 6 months, and then they stop having success losing weight with just the phentermine alone. But what we can see is those patients that maintained it beyond 6 weeks, or 6 months, out to 12 months, and then out to beyond 12 months to 24 months, they actually maintain that weight loss over time. And so we know that it actually is more effective and makes a lot more sense for weight maintenance to continue the medication long term. And we really need to consider that sustainability piece when we're treating patients. For this particular patient, she wanted to get pregnant, so she had to go off the medication before trying to get pregnant, and we did talk about that. We also know that phentermine can be beneficial in terms of disease prevention. And so this was a study that looked at patients at risk for progression to type 2 diabetes. So they had metabolic syndrome, they had high A1C, and or impaired glucose tolerance from glucose tolerance tests. And so those patients would be prone to going on to diabetes. And this was done with phentermine topiramate combination, not phentermine alone, but it showed a 71% reduced risk of progression to diabetes in the lower dose, and 79% reduced risk of progression to diabetes in the higher dose. And if we compare that to metformin, that we think about using preventively in that way, metformin reduces that risk by about 30%. So those aren't head-to-head studies, but it seems reasonable to think about using this in terms of prevention of progression to diabetes. So let's switch gears a little bit here to this patient, Jay. And, Jay looks like a lot of our patients where they really have multiple co-occurring medical problems with his obesity. And so he had hypertension, dyslipidemia, sleep apnea, metabolic associated fatty liver, diabetes, and non-obstructive coronary disease. He's already on multiple medications for all of these different conditions. And you can see his A1C is not well controlled at 8.1. His non-HDL cholesterol is elevated significantly at 194. Blood pressure is really not in good control. His BMI was 34 and his waist circumference was 48. And I would say, I'd actually do waist circumference, hip circumference, and neck circumference on all my patients. And I check it periodically to see how they're doing. But it really actually can portend, as we had with our, pre-test question, it can actually portend increased risk for patients. So at a similar BMI, having that higher waist circumference puts them at greater risk for metabolic disease and poor outcomes. And so we really want to think about that. When I measure waist circumference, I just put the tape measure at the top of the patient's iliac crest, have them hold it there, and then have them spin in a circle. And that's an easy way to do it. That's, I think, most comfortable for patients, and we can get a consistent measurement every time. But this patient, because he had these multiple medical problems, I really was hoping to kind of get the most bang for my buck and kind of try and address everything at once. And so I actually would consider putting him on tirzepatide, followed by a dietitian, whole food nutrition plan, of course, and then monitored exercise program, because I'm lucky enough to have a multidisciplinary team, that I work with. And he also did great, with this particular choice. He lost 24% at 12 months, which is really significant and makes a big difference for his risk. His A1C went down to 6.5 by 6 months and by 5.8 at 12 months, but that's also including taking him off of medication. So we were able to stop the glimepiride and continue to have that really good glucose control. He lost 12 inches at his waist, his LFTs and his FIB4, so his signs of his metabolic associated fatty liver improved, blood pressure normalized. We were able to take him off another medication for that. And his non-HDL cholesterol decreased significantly as well to 148. So he really did very well with this medication. So these newer anti-obesity medications, I think, can be really helpful. But let's think about, how do we reduce risk for patients, when we treat obesity. And so we talked about this waist circumference. And as it turns out, for patients, with obesity, they're already at higher risk for metabolic disease, but that waist circumference puts on added risk for them. And so a patient, and our patient had a BMI here of 34. You can see that that actually, with that waist circumference of 48, puts him at very high risk versus sort of high risk for patients, patients without that high waist circumference. And so when we think about our question, we can kind of come back to this question here. So he's 50-year-old Caucasian patient with a body mass index of 34, and it's categorized as class 1 obesity. If his waist circumference is 48 inches, what is his disease risk relative to normal weight and waist circumference? And so now that we've reviewed this, we'll have people go ahead and put in their answers. Excellent. So it looks like we have kind of most of our answers in. Yeah, and so actually, if we look back, and let's see if I'm going to shut that down and see if I can keep moving my thing. It's having trouble moving my slide. Hold on. There it goes. So if we look at his, BMI and waist circumference, it actually puts him at very high risk relative to high risk if he didn't have an increased waist circumference. So very high would be the right answer on that particular question. that, treating obesity can also reduce his other complications, right? So if he loses 3 to 10% of his body weight, he will really decrease his risk with his diabetes. With hypertension, as little as 5% weight loss can decrease risk, and it continues to decrease his risk to above 15%. And I know we sort of Jacinda went over this the other day, so I won't belabor it too much, but what we can see is the dyslipidemia, hyperglycemia, metabolic associated fatty liver disease, obstructive sleep apnea, all of these conditions that he was struggling with actually improve significantly with even modest weight loss of 3 to 5%, but it continues for a lot of these things as he continues to lose weight to reduce risk even further. When we think about these medications, these newer anti-obesity medications that we consider highly effective anti-obesity medications, the reason why we say that is because when we look at weight loss with these patients, they actually have really significant changes in their weight. And so with semaglutide, the step 1 trials showed, this 14-15% weight loss on the medication. And actually about, more than 50% of patients in the study lost 15% or more of their body weight over the trial time period of 68 weeks. And then if we look at tirzepatide, the SURMOUNT study, looking at the several, different doses, on the lowest dose, patients were losing about 15% of their body weight. At the 10 milligram dose, 19.5% of their body weight. And at the 15 milligram dose, they lost almost 21% of their body weight, with more than 50% of those patients actually lost at the 10 milligram dose actually lost, more than 20% of their body weight. So we see that these really significant changes relative to, our older anti-obesity medications, which we typically were seeing about 5 to 10% body weight loss with those medications, which we saw as beneficial for the medical conditions for sure, as well. But we see that there's some significant weight loss with these newer medications. When we look at the SURMOUNT trial, looking at, patients, again, this is without diabetes. This is just another way of kind of looking at that. We see those percentages that they're about the 18, to 20% range that patients are losing. And then when we look at patients who take these medications, who have obesity and diabetes, it's interesting because in the study, for example, with tirzepatide, they didn't lose quite as much weight as those patients without diabetes, but they were still really they were still really successful with it. And so they lost around, 15% of their body weight loss with the highest dose. But we did see a significant drop in the hemoglobin A1C, which is really, really helpful in terms of reducing risk, obviously, and patients getting healthier. And about 92% of patients in the SURPASS trial with tirzepatide actually got their hemoglobin A1C down below 7, which of course is a goal that we're trying to reach. And then, let's see if I can. One of the things that they did as well is they were looking at reduced risk of cardiovascular disease in patients without diabetes who are on semaglutide. And as it turns out, those patients did actually have decreased risk of major adverse cardiovascular events on the 2.4 milligram dose. And so it's actually been approved by the FDA as an indication for the medication. And so we can see the SUSTAIN 6 trial. This one is one with patients with diabetes. They also had reduced risk with the semaglutide and their cardiovascular endpoints. The SURPASS trial was type 2 diabetes, also showed trend towards benefit as well, decreased risk of MACEs with tirzepatide. And then with other disease conditions, glycemic control we talked about, but we also see significant changes in cholesterol. So, all numbers of cholesterol are improved. The HDL goes up, the triglycerides go down, LDL goes down. But we see really that high risk non-HDL, which is notable for, a significant drop in triglycerides. And then that increase in HDL really improves, which is improving patients' risk, decreasing their risk of major adverse cardiovascular events. There are also improvements seen with metabolic associated fatty liver disease in trials with semaglutide and also with tirzepatide. The semaglutide trial was really done, they actually did it with liver biopsy, and they saw decreased MASH, and they saw no worsening liver fibrosis. And then the SURPASS trial with the tirzepatide was looking at MRI assessed fatty content of the liver, and it went down significantly with the tirzepatide as well. So that patient, you can see, he actually had really significantly reduced risk from the one medication of multiple medical conditions. There was a study that just came out in New England Journal this past summer that showed, looking at tirzepatide and obstructive sleep apnea, and apneas and hypopneas actually decreased by 50%, almost 50% in patients who were on tirzepatide. So there's significant improvement of sleep apnea as well. And so if we look here at side effects with the GLP-1s, most of them are actually gastrointestinal. The most common thing that I tend to see is kind of reflux, nausea. The diarrhea is very common, but patients can get constipation as well. And so a lot of times you're having to sort of, work with them on, fiber and other things to kind of keep things moving along. In terms of the reflux, really thinking about reflux precautions, decreasing fatty content of the diet can be really helpful, but also to decrease these risks. We most often see it, at the beginning when we first start patients on the medication, and then each time we increase the dose. And so one of the things you can do is just increase the dose more slowly if patients are symptomatic, or back down to the previous dose if they're symptomatic, and then titrate the dose more slowly. But it's important to recognize as well, this can be a very significant complication for patients. And we see patients sometimes can get actually malnourished. So this is not a medication. These are not medications that you can just start the patient on and then give them all the titration and see them back in 6 months. You really want to follow closely, make sure they're getting adequate nutrition. Are they getting adequate protein? Are the side effects preventing them from eating at all? And so it's really important to watch that. So we'll go on to our post-test question number 2, this question we saw earlier. To facilitate shared decision-making, what counseling and educational points would you provide a patient regarding second-generation anti-obesity medications to allow them to make informed decisions about their therapy? So I'll let you look at that real quick here. Yeah, and that's fantastic. Obesity is a chronic disease, and the therapy works while they're taking it and can be, very effective. It, makes physiologic changes while they're taking the medication. So that's exactly right. And then, I'm sorry, I had trouble. I got to click off it there. And then this one, a second-generation anti-obesity medication was initiated in your patients 2 weeks ago. They report that they've been experiencing some gastrointestinal issues. Which of the following is the best way to manage those common side effects? I don't know if you popped up the option to make choices. I'm not seeing it. Oh, there it is. That's great. Everyone's still with me here, I can see. And so it's absolutely right that we want to titrate that dose more slowly, and that really can make a difference in the patient's symptoms. Oops, let's see here. So let's look at this next patient. I'm going to check my time here. Great. This is the next patient. He was a 55-year-old gentleman who came to me with some chronic medical conditions. He had hypertension, sleep apnea, some osteoarthritis. He had some hyperglycemia with his A1C or insulin resistance with A1C at 5.8, hypertriglyceridemia as well, which reflects that insulin resistance. And then his non-HDL was elevated at 160. He really came to me describing, he said, I can't do the things that I used to enjoy. He liked to go hunting and he'd go on these long hunting trips, which required, a lot of walking, and they would walk for 10 hours, 12 hours a day. And he just couldn't do it anymore. He felt like he couldn't keep up with his friends. He couldn't do the things he liked. He described feeling hungry all the time. And he also talked to me that he kind of felt like he was eating to overfull twice weekly. And so when I was thinking about this patient's picture, I was really asking about, when you're eating to overfull, could this be kind of binge eating? Could he have binge eating disorder? He actually screened negative for eating disorders. But I think it looks to me like what I call hyperphagia, or what we think of as hyperphagia. And hyperphagia is really that a decreased recognition of satiation, right? You don't recognize fullness during a meal. A lot of times patients have decreased satiety as well. So they're kind of feeling munchy between meals or snacky between meals. There's, they tend to have a preoccupation with food frequently or all the time. That's just sort of these intrusive food thoughts that are really bothersome to them. And he really described, having these kinds of symptoms when I talked to him, but there was none of the emotional distress that we think of, with like binge eating disorder. So when I treated him, I really wanted to think about, how can I address that kind of hyperphagia symptom? And so we think about this hungry brain part of the picture that I really wanted to address. The classic hyperphagia that we think of are those this MC4R pathway, which we treat with setmelanotide, and those are monogenetic causes of obesity, tend to cause those things. But for this patient, he doesn't look like he has a monogenetic cause of obesity. He just has this hyperphagia. And what I found is topiramate can actually be really helpful for that. Topiramate is used in patients with Prader-Willi for a number of symptoms, but they find it actually reduces that, that hyperphagia that those patients struggle with. And it's also used, it can be helpful in binge eating disorder as well. So topiramate works on this side, the orexigenic or increased food intake side, by inhibiting, this part of the pathway. It probably decreases NPY a little bit as well. And it really does seem to benefit those patients. So I really thought about using topiramate for this patient. But of course, he had insulin resistance. So I wanted to get him that benefit with a GLP-1. Unfortunately, he couldn't use the GLP-1, or he couldn't access it because of cost. It was cost prohibitive for him. We see this a lot with our patients. And I ended up using topiramate alone. He went on a partial meal replacement plan, monitored exercise program. He's working with my dietitian. And again, that behavioral assessment, I have a behavioral assessment on all my patients with my psychologist, and the eating disorder specialist didn't find any signs of eating disorder in this patient. But he did great, actually, just with topiramate alone. He ended up on 12.5 twice a day, and he lost 11.5% over 6 months. What was really telling, though, is he said he had no idea how much he was struggling with those intrusive food thoughts, and it just shut it down for him. He said he could recognize fullness at a meal. He could, he knew when he was done, even leaving food over on the plate. He just recognized that he was full and didn't need any more food, and was just living in a much more natural, comfortable way. It just improved his quality of life significantly. And that's how he was able to really lose this weight. His triglycerides went down, you can see, really significantly, and non-HDL cholesterol improved as well. So decreased cardiometabolic risk. He's exercising with strength training and high intensity interval training 6 days a week. And he got back to the activities he loves. So it was just so fun to have him come back to the office after he lost this weight. And he went on this, on this hunting trip. And he said, I did like 10 miles in a day, and I just felt great the whole time. And so just improved energy and really enjoying the stuff that he loves. So that was a great success story there. I'll kind of keep watching time here. So this is another patient, and you all may see patients like this quite a bit as well. She's 43 years old. And I do, like I said, I do these eating disorder screenings on patients, and one of them is it's called the Feeding and Eating Questionnaire. It has 18 questions, and it kind of helps me to determine if patients have tendencies towards restriction, if they have loss of control eating, or if they have signs of emotional eating. And her questionnaire really was suggestive of emotional eating. And so she also, she has hypertension, sleep apnea. She struggled with depression and anxiety and had signs of metabolic syndrome with that A1C of 6. She had seen her gynecologist, and they felt that she probably had some early menopause or premature menopause. Her BMI was 38. I have the non-HDL, listed here. It actually is not terrible, but I have it. We'll show you how to improve later. And so interesting, as I was thinking about choices of medications for this patient, she hadn't tolerated sympathomimetic amines in the past or bupropion. She had tried those previously, and it actually exacerbated her anxiety to the point that she really wasn't able to take those medications. So for this patient, I want to talk to you a little bit about perimenopause and menopausal symptoms and what happens to patients. As it turns out, estrogen actually impacts the hunger and satiety circuit in the brain. And so we can see that estrogen has stimulatory effects on this anorexigenic side, the decreased food intake side. It has inhibitory effects on the orexigenic or increased food intake side. And so when we have estrogen around, it kind of helps to, control hunger and satiety in the circuit in the brain. So you can imagine when we lose estrogen, we're losing, these particular features here. And so patients describe feeling, they're feeling hungry all the time. They feel they can't be satisfied with foods. They get very snacky, which is what we see in menopause. And we do see that patients struggle with weight gain when they go into menopause. What's interesting is estrogen also enhances the effect of paracrine hormones in the gut, such as GLP-1. And so it actually increases the anorectic effect of GLP-1 in the gut. And there also is effect on thermogenesis for, in the body as well. And so what we see is patients enter menopause. We saw the hungry brain stuff going on. So patients are hungrier with decreased satiety. They have this change in their gut hormones. So they have decreased satiety there. And then they have decreased thermogenesis. And so they actually get a body composition shift where you have decreased lean muscle and increased body fat, when they go through menopause in that first couple of years as patients enter menopause. So for this patient, I thought semaglutide would be a really good choice. Unfortunately, she could access it. We put her on whole food nutrition, just a low-cal, low-carb diet. She was referred to the certified eating disorder specialist because her emotional eating was really so bothersome for her and problematic. And of course, the monitored exercise program. And she did great. She lost 18% of body weight over 8 months. She actually lost about 3.3% per month when we looked at it over time. And it's interesting because patients, oftentimes what I find is patients tend to lose about the same amount per month when I follow it, but it's, body percentage, percentage of body weight lost. And so patients may find like, oh, I'm not losing as much weight because the absolute number goes down, but that 3.3% is pretty consistent. And so I like to show them that so that they can understand that they're still losing consistently. 85% of the weight that she lost was actually body fat, which is great. When we look at studies, typically when you lose weight, you lose about 75% fat and 25% lean muscle. So she was able to retain a lot of her lean muscle with eating adequate protein and getting that strength training. And her BMI went from that 38 to 31. Her A1C went down really nicely. And you can see her non-HDL, which was not high to begin with, was actually decreased by about 21%. So really significant improvement there. For some patients, they can't access, as we described, these newer anti-obesity medications. So oftentimes for patients who have this sort of perimenopausal or menopausal weight gain, what I like to try with them is a combination of phentermine and then metformin. The phentermine really helps with that sort of slow burn picture. It helps with the kind of, constant hunger, the hunger satiety that patients are feeling. And then I add the metformin for the insulin resistance resistance. And metformin is not really considered a weight loss medication. Some patients lose weight with it. It's actually most helpful in patients that have insulin resistance. And as I mentioned, those patients have decreased risk of progression to diabetes when we use that medication early. And it looks like in studies that it actually may increase the secretion of GLP-1 and also PYY as part of its mechanism for impacting hunger and satiety. So when I look at medications and how I choose medications, if I'm thinking about treatment based on phenotype, this is sort of a rough, chart of how I kind of think about these things. So hungry brain patients, I probably would consider doing phentermine or phentermine topiramate. Hungry gut, with that decreased satiety, that hunger between meals, we'll do a GLP-1 or the combination GLP-1, GIP. Patients with slow burn, I like to try phentermine first. Patients who are menopausal, like I said, phentermine metformin is helpful. I've used phentermine topiramate in those patients as well, and a GLP-1 or GLP-1 GIP combination can be really effective, as we saw, because of those estrogen effects. When I think about patients who are really predominantly hedonic eating or emotional eating, I try bupropion alone or bupropion naltrexone. And, for eating disorders, we often use naltrexone for binge eating disorder, using naltrexone alone. So that's something to consider as well. And then patients with that hyperphagia, I find that topiramate can be really helpful for those patients. And then for patients with with monogenetic obesity, setmelanotide is what we use. I realized too, now that I'm seeing this, the topiramate, I didn't really talk about side effects, but the most common side effects with topiramate that I see that are bothersome are the paresthesias, and people get a little bit of foggy brain. At the doses that we use, like I said, that 12.5 twice a day, we don't tend to see too many side effects with it. So it's usually manageable and controllable, but it can be a problem, with that medication. And then you do want to be careful. Again, you don't want to get pregnant if you're on topiramate. I want to be careful about patients who have metabolic acidosis chronically for any reason. Patients who have a history of kidney stone, it actually worsens and can promote kidney stones, and it also can promote gout. So those are things to kind of think about. And then it can be a problem like the phentermine with glaucoma. And so we do want to be careful in those patients if they have any vision changes with it, or if they have eye pain. I always tell them to stop right away and we get them checked out. Metabolic associated fatty liver disease, we think about the GLP-1s, or again, that combination with metformin. And then binge eating disorder is just sort of an aside here, we didn't get into too much, but Vyvanse can be very helpful for those patients, or topiramate has also been shown to be beneficial. So when do we think about, if you're in primary care and you're not doing this all the time, when might you refer to a specialist or multidisciplinary program? And I think about, if you're working with a patient and despite what you've been doing with them, they're really not improving over a period of 3 or 6 months, it might be time to consider a multidisciplinary team approach. Maybe a patient has has multiple chronic medical conditions that make the management of their obesity complicated. So that might be a reason to refer. You may find that you don't have time or support to treat patients with obesity, or you don't feel like you have the expertise. And so if you don't, I always say we should do what we enjoy most, right? There's lots of providers around, where, at least in town here, so they can get the help that they need from specialists if you feel like you can't support them. And then patients who have symptoms to suggest disordered eating would be a time to refer as well. So that's all that I have. And so I see that there are questions in the chat, but we'll see if there are any other questions that people have for me now. I got to get to the chat, I guess. So I'm going to say that, or I don't know if you want to read.
Yeah, let me read them to you.
questions for me.
I wrote them in the order I saw online, but some are coupled together. So one was, you brought up pregnancy. Any considerations for patients who become pregnant when on a GLP-1 RA? I've had 2 patients who got pregnant while using them.
Yeah, and so current guidelines are to stop the medication, right away. And so in general, right now with the recommendation on GLP-1s, we don't want to use it during pregnancy. And so I would have the patient stop the medication right away. For patients, for example, I see patients for pre-fertility, and the obstetricians, maternal fetal medicine specialists are usually having us stop the GLP-1 2 months prior to a frozen embryo transfer. And so, so we do want to stop the medication before patients try to get pregnant. And so, like I said, when I start anti-obesity medications, I want to think about that. And I do put patients on birth control, when they're taking these medications, because we don't want them to get pregnant on the medications.
Okay. And then another question was, my patients said they don't want to eat when my patients say they don't want to eat when on these drugs. I try to talk to them about small meals. Should I be pushing protein above all? Which is kind of coupled with another question that says, do you have to go on high protein or just eat a normal diet?
Yeah, and so that's an excellent question, right? And because that's what I see as well. A lot of patients, their appetite goes to zero. And so that's why I say I would titrate it very carefully and very, pay attention to what's going on. What are the symptoms? We don't need patients' appetites, and I don't think patients want their appetite to go to zero, right? And so, a lot of my patients do great on the 0.5 milligrams weekly of the semaglutide, or the 5 milligrams weekly of the tirzepatide. They do really well. And so if their appetite is decreased, and their symptoms are controlled, I don't need to keep increasing it, because it can be really problematic if they're not eating. And, Eating Recovery Center, we've seen lots of patients come in malnourished because they go for, weeks or months without eating much of anything at all. So it can really be dangerous. And so what I would say is back off to the previous dose. If the patients are saying, I can't eat, I don't feel hungry at all, or managing symptoms. So if patients are on semaglutide and really symptomatic, you might consider trying tirzepatide to see if they're less symptomatic so that they can eat better. And I do really focus on protein. And so, you want to get adequate protein. And to me, adequate protein is 1.2 grams of protein per, kilo of ideal body weight per day. And so, so trying to get in for the average woman, that's going to be, around 100 grams of protein a day. And so it's really, we got to get that protein in. And so I really encourage them. And sometimes we have to work on it with meal replacements, or, protein, kind of supplements with protein powders and stuff into their whole food to make sure they're getting enough protein, is how I manage it. But I think if your patient says, I just can't eat, back off to the previous dose, because they don't need that much.
Great. Okay, what can I do with my patients with GERD or IBS when I start them on a GLP-1?
Yeah, and so that can be really tricky, because it can really exacerbate GERD. So you certainly want to make sure that it's optimally treated. I think there is some benefit for those patients that when their nutrition improves, the GERD can get better as well. Their reflex can improve just from improvements in their nutrition. But I would really optimize their PPIs and their treatment for their GERD. Really talk to them about reflex precautions. Smaller, more frequent meals can be really helpful for that, and really decreasing the fat in the diet. So, fat actually can exacerbate those symptoms, because that also slows gastric emptying even further and can make it much worse. And so if you reduce the fat in their diet, it can really help those symptoms as well.
Okay. And last question that I have online, can patients start and stop these medications, sometimes because of insurance, sometimes because of the cost, sometimes because they've gotten to goal and want to stop taking it?
Yeah. And so this is the tough question, right? The reality is that obesity is a chronic medical condition, and it really Medications work when we take them and they don't work when we're not taking them. And so for any anti-obesity medication, just like if I had someone on an antihypertensive, medication, if I took them off of it, I would expect their blood pressure to go up. When I take patients off anti-obesity medications, I would expect that their weight would go up over time. And I would say, I have patients who are really very, routinized with their nutrition plan. They exercise regularly and they go off the medication and the weight will start to creep up again. And it doesn't matter which medication, the reality is it works when they're on it. And so, like I mentioned, we really want to think about sustainability. So if we're putting patients on, an expensive medication that they're not going to be able to continue long-term, we have to think about what is our long-term plan. So maybe I'll transition them later, maybe to phentermine or low-dose phentermine. Maybe we need to think about, can we spread out the dose or reduce the dose to make it more cost-effective to use for maintenance long-term, right? Or trying some other medications for long-term maintenance. So I really want that to be part of my plan whenever I put patients on medication, is how am I going to help them maintain the weight? And I always tell patients, this is a chronic medical condition, and my expectation is that you may gain weight if you stop the medication. So a lot of patients are like, I don't want to be on medication long term. And so we have those conversations like, let's watch closely. I follow them up, frequently, especially through maintenance, to make sure that if things are kind of shifting and we need to change things, then we can. But I tell patients, if you want to go off with it, let's try, but I watch very closely, and maybe we have them on it periodically so that they don't have significant weight regain. But I think you want to think about, letting patients know, we're in this together for the long term, because the expectation is that there can be weight regain, and I really want to support you when you need me. And so just following up patients regularly to make sure we can help them with that.
Okay, thank you.
Mm.
Fantastic. I think we're at time. I did want to remind everybody to come next Tuesday to the Welton Room in Denver, 6:30 to 8:30. Again, no slides, just conversation and asking questions, getting your questions and cases answered. So thank you so much. There's a QR code on the screen to take the evaluation for credit. I really enjoyed this evening. Thank you so much.
Thank you so much for coming.